My name's Kristina Gaietto. I just wanted to thank everyone for attending today's journal club through the American Thoracic Society's Assembly on Pediatrics. Today, we'll be discussing the article, Extended Continuous Positive Airway Pressure in Preterm Infants Increases Lung Growth at 6 months, a randomized control trial. And we are really fortunate to have Dr. Cindy McAvoy today presenting this article. She is a professor of pediatrics at the Oregon Health and Science University Dornbecker Children's Hospital, where she is the Credit Unions for Kids Endowed Professor in Pediatric Research, the Director of Maternal Child Health Research for the Pediatric Department, and Director of Research in Neonatology. She is a neonatologist and physician scientist whose research interest is on the primary prevention of childhood respiratory disease through in utero and early life interventions, with a focus on the use of pulmonary function testing to quantify outcomes. Today, she'll present the results of one of her NIH-funded randomized controlled trials published in the American Journal of Respiratory and Critical Care Medicine, titled Extended Continuous Positive Airway Pressure in Preterm Infants Increases Lung Growth at 6 months, a randomized control trial. And with that, I'll turn it over to Dr. McAvoy.
Let me introduce our panelists. Hi, I'm Mitzi Go. I'm a neonatologist here at Oregon Health and Science University. I would like to introduce our panelists. The first is Dr. Stephanie Davis, and she is the Kernan Professor and Chair of the Department of Pediatrics at the University of North Carolina at Chapel Hill. She's a world-renowned expert in pediatric pulmonology whose research is focused on diseases that affect the lungs of infants and children. And her research aims are to slow or prevent disease progression at the earliest stages of development. She has extensive expertise in infant and preschool lung function testing and has been a member of many national and international consensus groups responsible for establishing guidelines for the diagnosis, monitoring, and treatment of infants and children with pediatric respiratory disease. Next is Dr. Divya Chhabra, as she's an assistant professor at the University of Rochester Medical Center. She's both a pediatric pulmonologist and a neonatologist, and her research interest is in using large-scale data and machine learning to better predict BPD. She also runs the BPD clinic at URMC and is the pulmonary representative of the pulmonary hypertension team in their center. She's soon actually moving to start a new position at UC Davis in Sacramento. Dr. Leif Nelin is a division chief of neonatology and the Dean Jeffers Endowed Chair of Neonatology at Nationwide Children's Hospital and professor of pediatrics and chief of neonatology at the Ohio State University College of Medicine. His research interests include developing therapies and approaches to improve long-term outcomes of infants with established BPD, starting with identifying whose patients at highest risk for adverse post-NICU outcomes. And Dr. Nelin has been involved in several national groups focused on improving outcomes in severe BPD patients. He has also helped found and implement the BPD Collaborative, a collection of centers that have dedicated BPD teams committed to improving outcomes of infants with severe BPD. Dr. Namasivayam Ambalavanan is a professor and the Virginia Walker Jones Endowed Chair in Neonatology at the University of Alabama at Birmingham. He's also the director of the Translational Research in Normal and Disordered Development program and the Division of Neonatal Research at the University of Alabama. The focus of his research is on biomarkers and prediction of outcomes in premature infants, and have more recently published on genomic analysis in BPD, intercenter variations in outcome, and prediction models of extremely premature outcomes. Last but not least is Dr. Stephen Welty, is an emeritus clinical professor with the Division of Neonatology at the University of Washington, and he's the medical director of the Franciscan Health System Neonatal Service Line in the South Sound area. He is one of the founding members also of the National BPD Collaborative and remains involved in an advisory capacity. He's also the chairman of the DSMB for Dr. McAvoy's proposal with the extended CPAP therapy that she's presenting today. Now, Dr. McAvoy, you can start your presentation. Thank you.
Great. Thank you so much. I'm really excited to be here today to talk about our recently published article. So I'm going to talk a little bit first about the potential benefits of CPAP and extending CPAP in the nursery, and then talk about the specifics of our published article. I have several NIH grants, but no conflicts to disclose. So as we all know, altered lung development really can be seen in all preterm infants, even those who don't initially have clinical lung disease. And we know that preterm infants are at increased risk for wheezing, increased risk for asthma and respiratory hospitalization, compared to infants born at term as these infants begin to age into childhood. And we know that since an individual tends to follow along a pulmonary function percentile that's established early in life, preterm infants with altered or diminished lung function can have limited lung function throughout their life. And this is shown in the figure here to the right. So here we have lung function on the y-axis and we have age on the x-axis. So if we follow along this blue line as representing healthy children born at term, we know that there's a continuous growth of the lung and thorax till about 22 years of age. And then unfortunately, we all have a very slow decline in our lung function as we age. But most people don't develop lung disease unless there's an accelerated decline because there's a lot of reserve. But now if we look at the early part of the curve where most of us practice, and we look at the red line as representing abnormal lung development, and in this instance, preterm delivery, you can see that even with the normal growth of the lungs, these babies never reach their normal potential as young adults, and they're going to be more prone to develop lung disease as they age, even with a normal decline. So focusing on the early part of this curve in terms of prevention has been our focus. And as we also all know, nasal CPAP really continues to be the cornerstone of NICU care for the acute management of infants with respiratory distress and provides a number of very important physiologic benefits to the preterm lung, including maintaining functional residual capacity or lung volume and improving oxygenation. And we know that the initial use of CPAP right after delivery has been very well studied as we try to avoid iatrogenic damage to the lung and avoid intubation. And its application right after delivery is the standard of care, even for the smallest of infants. So this is a forest plot from the 2021 Cochrane review of the use of prophylactic CPAP versus assisted ventilation, looking at the outcome of BPD diagnosed at 36 weeks of age. And it includes many of the big trials, the COIN trial, the SUPPORT trial, and the Vermont Oxford trial of early application of CPAP in extremely low birth weight infants. And as we know, these lines show the risk ratio in the 95% confidence interval with a risk ratio of less than 1, indicating or favoring CPAP use. So overall, this meta-analysis showed a small but significant decrease in the incidence of BPD with a risk ratio of about 0.89. And it also demonstrated, the review also demonstrated a significant decrease in the risk of BPD or death with early use of CPAP right after delivery. But even though the initiation of CPAP has been very well studied, there really has been a knowledge gap with regards to what is the optimal duration of CPAP. And older reviews examine some of this, and practices were shown to differ between units and even within units. Earlier surveys from English and Australian NICUs showed different methods with regards to how to determine if an infant was ready to come off CPAP, either the use of respiratory stability criteria, which could vary. Also, other units use specific postmenstrual ages. Also, the methods of weaning the infants off CPAP was also shown to vary greatly. Some would try to decrease the amount of time that patients were on CPAP each day. Some would transition to other forms such as high flow or low flow nasal cannula. And if we take a step back, really the question is discontinuation of CPAP a success? And oftentimes the parents are advocating for the patients to come off CPAP. And in the minds of the nurses, it maybe is easier to manage the patients off of CPAP. And we know CPAP can have some adverse events. Or is there a different way for us to think about CPAP therapy? And this is a figure from a review from Baumont and Kirpolani of trials looking at CPAP discontinuation. And here we have the percent of infants failing the initial wean off CPAP on the y-axis and the different studies on the x-axis. And the review at that time of published trials demonstrated that overall there was, at that time, a small number of trials with low data quality and quite a bit of heterogeneity. Again, some studies would wean off CPAP if certain stability criteria were met or at a specific postmenstrual age. And really the take-home message of their review was that time cycling the infants off CPAP by increasing the time off each day was unlikely a benefit and could actually have caused harm because of the loss in functional residual capacity. But prolonged CPAP use seemed to diminish supplemental oxygen need. And as shown in this figure, there was quite a range in weaning failure rate of 22% to almost 70% in these trials. So this study demonstrated that more randomized controlled trials were needed, and also spoke to the large percent of infants who failed their initial wean. So what's happening in more current times here in the United States? One of our fellows administered a web-based survey inquiring about the initiation, management, and discontinuation of CPAP through the American Academy of Pediatrics neonatal perinatal section. And we received 857 responses back. And in terms of the methods that are being used to wean off CPAP, 37% of respondents would discontinue CPAP directly to room air. About 60% would transition the infants from CPAP to high flow or low flow nasal cannula. And about 5% would do a sprinting type of process where they would increase the time off of CPAP each day. As shown in the figure to the right, we also asked about the criteria used to determine when to wean. And the respondents, about 69%, used some respiratory stability criteria that could vary between nurseries and even within nurseries. 22% would use a specific postmenstrual age, and about 8% would use a combination of these. So again, kind of taking a step back and thinking more about it, early CPAP use really can benefit the preterm lung by minimizing injury. But there is quite a bit of clinical and animal data that is accumulated indicating that mechanical stretch of the lung with CPAP may provide an important benefit in stimulating lung growth. And in the past, in our haste to simplify management or get the infant off CPAP, are we missing really the opportunity to optimize the use of a potentially important therapeutic modality that could really stimulate lung growth and development? And for instance, the Columbia experience, which has been the model for others to use early CPAP to avoid intubation and has had really the lowest incidence of BPD for a long period of time, their practice is to continue CPAP almost until the infant is discharged. So again, thinking about CPAP and what the optimal duration is, have we been kind of throwing the baby out with the bathwater, shall we say, and could really an answer to improved lung health be under the infant's nose? And there's data to show that chronic stretch from CPAP could benefit lung development. The first study listed here was done by Velos and Liggins in sheep fetuses who were 122 to 145 days of gestation. And in this study, they measured pressures by open-ended catheters in the trachea, the intrapleural space, and amniotic cavity. And these investigators demonstrated that in utero, the transpulmonary pressure of the fluid-filled lung is about 3 to 4 centimeters. There's also been studies showing that CPAP at 5 in humans results in a nasopharyngeal descending pressure of about 2 to 3 centimeters of water. And in a non-human primate model, we have been able to show that CPAP of 5 at the nose distributes about a 2 to 3 centimeter descending pressure to the lungs. And we'll talk about that in the next few slides. And so while one approach to stimulate lung growth has focused on fluid-filled lungs, mechanical distension of air-filled lungs can also increase lung growth. And really, these studies give in utero physiologic support for the hypothesis that spontaneous breathing at a constant low descending pressure, as can be provided by CPAP, could provide mechanical similarities to the lungs as they see in the intrauterine environment and promote lung growth. We know of a number of antenatal processes that alter mechanical forces, such as congenital diaphragmatic hernia, and decreased breathing movements, decreased amniotic fluid, which impair lung growth and can result in pulmonary hypoplasia. We know that the diaphragmatic hernias encroach on the lung during fetal development and prevent in utero lung expansion, and this results in a hypoplastic lung after birth. In contrast, we also know that complete congenital airway obstruction, bilaryngeal or tracheal atresia, prevents lung fluid from leaving the trachea, and this can produce a large hyperplastic lung. So as an approach to treating CDH in utero, animal models have shown that experimental occlusion of the fetal trachea increases the lung distending pressure and can result in increased fetal lung growth, and also increased fetal lung distension can stimulate capillary growth and epithelial branching in the fetal lung. So there's a number of preclinical and clinical studies, again, demonstrating the potential positive impact of CPAP on lung development. So these studies include showing that CPAP improved lung function in former preterm infants and in an animal model. Also that CPAP can decrease airway reactivity, promote lung development, decrease inflammatory cytokines, and also increase expression of angiogenic growth factors. So this is a figure from one of these studies, and this was done in tracheostomized ferrets by Zhang et al. And these ferrets were placed on CPAP at 6 centimeters, and they're shown in the black bars, or at atmospheric pressure, as shown by the white bars. And total lung capacity was measured at baseline, and then at 1 and 2 weeks afterwards. And after 2 weeks of CPAP, the total lung capacity of the CPAP treated group was about 40% higher than that of the control group. And this was really associated with significant increases in lung weight and total lung protein and DNA contents when compared to the controls. And very interestingly, the lung recoil between the two groups remained the same. So this seemed to indicate that the mechanical strain was associated with an acceleration of lung growth in these immature ferrets, and not likely just an increased distension, but really likely remodeling of the lung parenchyma. And here at our Oregon National Primate Research Center, we also performed a cross-translational study asking the question whether the application of CPAP to moderately preterm primates could promote lung growth as well as angiogenesis in the premature lung. And I put this in just to show this is our NICU out at the Oregon National Primate Research Center. You can see you can't even tell it from a human NICU. And we had a fully functional NICU with 24/7 bedside nursing care that occurred from resuscitation to the placement of a PICC line. These infants got TPN and breast milk. Unfortunately, unlike human babies that we were able to swaddle and keep them quiet when we put them on CPAP, these primates have very long arms for a reason, so they would pull their CPAP out, so we had to keep them sedated during this time. So they were sedated for 12 hours a day for 10 days, and again randomized to being on CPAP versus sham CPAP. And with this study, we were determining whether the CPAP for the 10 days could stimulate lung growth and also suppress airway reactivity. Both of these, the infants who received the CPAP received it through Hudson prongs and got bubble CPAP. And at the end of the 10 days, the babies were taken for measurements of lung function testing, as well as evaluation of lung structure. And we also studied gestational controls who were not treated with CPAP. And this is some data from these survivors, which showed that the CPAP treated infants, here shown in orange, had a significantly increased number of total alveoli compared to the sham treated, which are shown in gray. And we also, as I said, studied gestational controls for comparison, and those infants are shown here in blue. And also you can see from the seriology here to the right that the sham babies, which are A here to the left, demonstrated fewer and larger alveoli than the CPAP-treated babies. And we just published this paper in the European Respiratory Journal. So with all of this background in mind, we did a pilot study which we published in 2020, in which we randomized preterm infants born at less than or equal to 32 weeks who met specific respiratory stability criteria when they were on CPAP. And these infants were randomized either to CPAP discontinuation to room air, which was our standard practice here at OHSU, or to 2 additional weeks of CPAP. And then we performed measurements of functional residual capacity, or FRC, shown here on the y-axis, at the time of randomization, and then at the end of the 2-week treatment period, as well as before discharge. So in this figure, the green represent the infants randomized to the 2 extra weeks of CPAP, and the pink are the infants randomized to CPAP discontinuation or room air. And the solid lines denote the treatment period of randomization, and then the dashed lines denote the time from the end of the treatment to discharge. So as you can see, at randomization, the FRC between the 2 groups were very similar, but at the end of the 2 weeks of treatment, those who received the extended CPAP had significantly higher FRC measurements. And also, even though all of the infants were off CPAP during this time period before discharge, the infants who received the extra 2 weeks, again, had significantly higher measurements of FRC. So from this pilot study, we concluded that the stable preterm infants born at less than or equal to 32 weeks of gestation and then randomized to 2 extra weeks of extended CPAP have a significantly increased change in FRC versus those who were weaned to room air as per our standard of care at OHSU. And of note, during the study, there were no significant adverse events in either arm, and particularly the eCPAP arm. And only 1 infant failed the wean to room air, and there was no difference in the postmenstrual ages at full nipple feeds between the 2 groups or at discharge between the 2 groups. So from this pilot study, we speculated that an increased change in FRC could lead to improved respiratory health, but unfortunately in that pilot study, we were unable to continue to follow the patients after discharge, and that extended CPAP could ultimately reset subsequent pulmonary function trajectories, but really additional trials of CPAP duration were needed, looking at longer term outcomes and trying to begin to look at underlying mechanisms. So we were fortunate to receive funding from the NHLBI to further investigate the effect of extended CPAP and begin to answer some of these questions. So with the new trial, our specific aim 1 was to establish whether the 2 additional weeks of bubble CPAP in the nursery for stable preterm infants increase alveolar volume as measured at 6 months of age. Our specific aim 2 was to evaluate whether those 2 extra weeks of CPAP increase lung diffusion capacity as well as forced expiratory flows at 6 months of age. And then we had several exploratory outcomes looking at respiratory morbidity as well as neurodevelopmental outcomes, and also looking at oxygenation patterns in this trial. So this gives an overview of the study. Here, focusing on the left, it was a randomized single-blind study we were unable to blind caregivers in the nursery, but everyone who evaluated the patients after discharge were blinded to the treatment in the NICU. The statistician was also blinded to the NICU treatment. It was done at a single center at OHSU. It was done with bubble CPAP administered through the Hudson prongs. And our inclusion criteria included preterm infants born at 24 to less than or equal to 32 weeks of gestation, who required at least 24 hours of bubble CPAP after delivery. And we excluded multiple gestations above twins. And the infants would qualify for randomization once CPAP stability criteria were achieved, and I've listed them here. The infants had to be on a CPAP of 5 in room air, had to have a consistent respiratory rate less than 60 breaths per minute without retractions, had to have less than 3 episodes of self-resolving apneas, bradycardias or desaturations in the 1 hour for the previous 6 hours, had to have an average saturation of over 86% for 90% of the time in the 24 hours prior to randomization, and had to not be treated for PDA or sepsis at the time of randomization and tolerating brief times off of CPAP for cares. So when those criteria were met, we performed a baseline lung function test of FRC in the nursery. The infants were then randomized, with half going to 2 extra weeks of CPAP and half going off CPAP. And we also had predefined criteria which would define when the patients were failing their assignment. And for instance, if they were weaned to room air, there were criteria that would cause them to be put back on CPAP. During the 2 weeks of treatment, we monitored them carefully for any AEs or SAEs. And then we performed another FRC at the end of the 2 weeks of treatment. And then very importantly, we followed them after discharge through, at 6 months of age, we performed the primary outcome of alveolar volume and lung diffusion capacity, as well as forced expiratory flows. And we also called the parents monthly to obtain a standardized respiratory questionnaire. And so I just put this in to show our pulmonary physiology lab here at OHSU. At the 6-month pulmonary function test, we measured alveolar volume and lung diffusion capacity with a single breath technique with an induced respiratory pause with a standard test gas. And this was done in collaboration with my co-PI, Dr. Tepper at Indiana University. And this shows our lab, which was when we're actually doing the testing, there's about 6 people in here with the patient. So it's very crowded and a very sophisticated test. And I always say this was a very cooperative patient here at the bottom. For everybody else, we had to use chloral hydrate sedation for our testing. And so we did the measurements of alveolar volume, lung diffusion, and then also we measured forced expiratory flows with the raised volume rapid thoracic compression technique. And we followed ATS and ERS criteria and had our tests overread by an outside observer, and our analysis was by intention to treat. So this shows our trial profile. We screened 276 infants, and we ended up enrolling 100 infants, with 46 being assigned to the discontinue arm, and 54 were assigned to the extended arm. When we had a set of twins who both ultimately ended up meeting criteria for randomization, the first of the twins who met those criteria were randomized, but the second twin was assigned to the same arm as the first twin, which accounts for some of this variability in the number assigned to each arm. We ended up with 46 infants having successful FRC measurements in the discontinue arm, and 52 in the extended arm, and these were done in the NICU. And then at 6 months of age, 46 infants assigned to the discontinue arm had successful measurements of alveolar volume and lung diffusion capacity, and 47 infants in the extended arm had successful measurements, and this met our predetermined sample size. We needed 76 infants at 6 months of age to be able to show a 12% difference in our alveolar volume. So in terms of our maternal and delivery characteristics, the groups are very comparable, as you can see, in terms of maternal age, as well as race, and also as well as education. They were also very comparable in terms of maternal diagnoses that can be important for subsequent offspring respiratory health, including asthma and preeclampsia. About 67% in each group were delivered by C-section. The gestational age of the infants of the gestation were basically exactly the same, 30.2 weeks in both groups. And there tended to be more twin pairs in the extended arm. And there was about 27% of the infants in both groups were less than 29 weeks of gestation. And this was one of our stratification variables. This slide shows our infant demographics at birth, as well as at our FRC measurements in the nursery. So both infants had very comparable birth weights, about 1430 grams. There tended to be more females in the discontinue arm. Very similar percent were treated with surfactant. And the postmenstrual age in both arms at the time of randomization was 32.4 weeks. Both groups were about 1580 grams at randomization and about 41 centimeters at randomization. So this figure shows the FRC measurements in the two groups of infants at baseline, at randomization, and then also at the end of the 2-week treatment. And our green line shows the infants who were randomized to the extra CPAP, and the pink are those randomized to discontinue CPAP. So at baseline, the two groups had very comparable FRC measurements, but at the end of the 2 weeks of treatment, the infants randomized to the extended arm had significantly higher FRC, as shown here, with a significant p-value. And these changes were actually very similar to those that we had published in our initial pilot study. So there was about a 16% difference here at the end of the 2 weeks of treatment. So we were able to complete successful or alveolar volume and DLCO measurements in 93 of the 98 available infants at outpatient testing. So that was a 95% successful completion rate. 46 infants in the discontinue arm had measurements and 47 in the extended. The birth weight of those infants who completed the 6-month test were very similar, about 1430 grams. There was no difference in the sex distribution, although there was a trend for more females in the discontinue group. There was no difference in race. There were more twin pairs in the extended arm. And again, the postmenstrual age at randomization in the infants who completed successful testing were very similar. The corrected age, both groups were tested at about 7 months of corrected age and about 8 kilos at that time, and had very comparable lengths. And all of those measurements are very important for lung function testing. So this figure shows our lung function results at 6 months of age, and our red bars show the infants randomized to the 2 extra weeks of CPAP, and the blue are those randomized to the discontinue group. And on the left here, we have our measurements of alveolar volume, which were significantly different at about 500 mils versus 418, so about a 20% difference. And then on the right, we show the measurements of the lung diffusion capacity, which were also significantly higher in the infants who received the 2 extra weeks of CPAP. And these p-values for the differences between these two groups were based on multivariable mixed linear models to account for the correlation between twin pairs. And then also we adjusted for the gestational age at birth, which was a stratification variable, as well as the sex and length at outpatient testing. We were able to complete forced expiratory flows in 76 of the infants at outpatient testing. And again, we're able to demonstrate that with the red bars indicating the extended CPAP arm, that the extended arm had significantly higher forced expiratory flows, including FEF 50 and FEF 2575 at the time of testing. FEF 2575, excuse me. FEF 75, the p-value was 0.06. And forced vital capacity was higher, but it did not meet significance in this group. We also followed the clinical outcomes through 12 months of age and administered a standardized monthly respiratory questionnaire. We were able to obtain a median of 12 respiratory questionnaires in each group, and demonstrated that the discontinue arm, the occurrence of wheeze was 56.5%. versus 43.4 in the extended arm, which had an adjusted p-value of 0.19. There were significantly more healthcare provider diagnoses of wheezy bronchitis made in the discontinue arm, and there was no difference in the reports of wheeze or cough without a cold. So in conclusion, from this recently published study, we conclude that stable preterm infants randomized to extended CPAP versus discontinued CPAP in the nursery have a significantly increased alveolar volume and lung diffusion capacity at about 6 months of age. And since premature infants have impaired alveolarization and vascularization, an increased alveolar volume and DLCO due to CPAP really may lead to improved respiratory health and may improve these infants' lung function trajectories over their lifetime. So a few take-home points. The extending CPAP in stable preterm infants may be a non-pharmacologic and safe therapeutic strategy to promote lung growth and development after preterm birth. And future studies really are needed to evaluate the optimal duration and magnitude of CPAP in the context of promoting lung growth and development. And continued longitudinal follow-up of this very important cohort really is required to determine whether extended CPAP in the nursery can continue to improve lung function trajectories and long-term respiratory health following preterm birth. A few limitations. This was a single center randomized controlled trial, which may limit generalizability. And it didn't include very preterm infants with the most severe respiratory disease because they didn't meet our CPAP respiratory stability criteria prior to 35 weeks of postmenstrual age, which was our cutoff for randomization. So our results may not be applicable to those preterm infants with more severe respiratory disease, but as mentioned at the beginning, all preterm infants are at risk for altered lung development and altered lung function trajectories. So with that, I have many acknowledgements, including funding support by the NHLBI, and looking forward to discussion with our esteemed panel. Thank you.
That was wonderful. Thanks, Dr. McAvoy, for that fantastic presentation. And I just want to say congratulations. This really is such a high quality trial that has a lot of potential to improve outcomes for stable preterm infants. So congratulations. Next, we'll hear some thoughts from our panelists, and then after that, we'll open it up to the audience for questions. Audience members can either unmute themselves and ask their question out loud, or you can type questions into the chat for the moderators to ask. But before we move to that part, I'd love to hear some preliminary thoughts from each panelist to kick off our discussion. So going through our panelists alphabetically, Dr. Ambalavanan, would you like to start?
Sure, just call me Ambal. So I think this is a really excellent manuscript. I think this work really shows that it's possible to impact the trajectory of lung development and lung mechanics. The one issue that needs to be addressed, obviously, is these infants were slightly larger preterm infants, more than 1 kilogram on average. And the ones who we think are at highest risk of BPD are obviously the extremely preterm infants, the ones who are less than 28 weeks. So I think the question would be, how do we extrapolate this strategy to infants who are extremely preterm, and what would be the optimal duration of CPAP in them? Would it again still be up to 34 weeks PMA or longer? And is there any specific criteria we use to find out which infants are suitable for this?
I mean, I agree with all your comments. Again, you know, the more moderate, even to late preterm infants are at low risk for BPD, but are at high risk for altered lung development and altered lung function trajectories. And really, although we've spent a lot of focus on preventing BPD, and it's extremely important, when you look at the actual absolute number of patients that are delivered preterm, those moderate and late preterms, and we didn't study late preterms, but looking at the moderate preterm make up more of the number. But I agree, there's still a knowledge gap in terms of focusing and trying to optimize the use of CPAP in the extremely low birth weight infants who are at risk for BPD.
Thank you.
Thanks. And then Dr. Chhabra, any thoughts?
That was a really great study. Thank you so much for discussing that with us too. I wanted to know, like, for your NICU, is there a protocol for like a minimum gestational age where you keep them on CPAP? Because I know our NICU will not take them off CPAP before 32 weeks gestational age. And is that why I think most of your kids were plus minus 0.8, that 32-week mark? So I was curious about that. And then the other thing that I'm always curious about with CPAP is like how families take it. I know you mentioned that briefly, that, you know, the discomfort of having CPAP and it kind of becoming a barrier with like holding the baby or something. So I know families consented for the study, but over the course of it, was their experience any different from the kids that were not on CPAP? And also, do you have long-term plans to follow these kids to see if the wheezing score changes as they get older or not?
All great questions. In terms of the families, who are incredibly important, obviously, because they're such an important shareholder in the study, as well as the bedside caretakers, et cetera. We did a lot of education with the bedside caretakers, as well as a lot of discussions with the parents. And we do, patients on CPAP in our unit do a lot of kangaroo care. So being on the additional 2 weeks of CPAP didn't impair the skin to skin time. And during the consent process, we always got a lot of great questions back from the parents, but they really embraced being in the study. And at the beginning, I have to say, many of the parents would be a little more prone, maybe not to do the study because they wanted the patients potentially to be off. And then as the study went on, I think that it was interesting because it switched a little bit where they didn't want to be in the study because they wanted their baby to stay on CPAP. So I think that it was just an interesting process as the study occurred. But they all embraced being in the study and really trying to contribute to the knowledge of what's the optimal duration of CPAP. And we follow our respiratory stability criteria, and we had first started this study. So we had very standard clinical consensus that we all followed at OHSU. And what we found from the first study and then the follow-up study is that those respiratory stability criteria, at least in our unit, were met at about 32 to 32.4 weeks. Now, because of this study, we are reevaluating and keeping them on a little bit longer because we don't have equipoise anymore.
Does that cause any like delays in I know you said that in the study there wasn't a delay in feeding, full feeding, but does it delay the initiation of feeding or breastfeeding for these families?
Right. So in our first study, we found no difference in those outcomes. And in this larger study, we didn't find any difference in terms of when the infants started nipple feeds, when they achieved full nipple feeds, or when they were discharged. So we found no differences in those outcomes.
That's great. Thank you.
Thanks. And then Dr. Davis?
Yeah, great. Thank you. Thanks, Kristina. So just a couple of things. I did serve on the DSMB for this study, just so everyone's aware. But Cindy, this is outstanding, and congratulations to your team. I just had a couple of comments and then a couple of questions. First of all, to get these kind of infant lung function is challenging and really reflects a lot of training, a very standardized operating procedure, and an excellent team that was able to do this single center study in Oregon. So congratulations to that. And the importance of following these children long term cannot be overemphasized because this kind of data is not going to be easily obtained again, quite frankly. So I hope that the NIH reviews your grant favorably to follow them out. So that's one comment. The second thing is the importance of intervening early and how this will potentially change the trajectory into adulthood, which I think Cindy showed that initial curve at the beginning about how early lung function really does follow long term, and the intervention is so important early. So my two questions are, one, we did infant lung function testing in a prop cohort, Cindy, where we followed those LGANs to 12 months and did infant pulmonary function test. And what we found in the LGANs were that the first year of life, if these children were hospitalized or had any kind of major viral hit, it wasn't BPD at discharge, but more of what happened during that first year that impacted airflow obstruction. So one question I have for you is, did you look at that in the first 6 months when you follow them up? And the second is, will that be taken into account when you follow them up long term? That was one question. And then I'll let you answer that and then ask my second question.
Those are great points. I think, the double hit theory of being born preterm and then having a respiratory tract infection, especially RSV. And so we have all of that data, and that will be incorporated into, as you mentioned, hopefully we get continued funding to follow this very important cohort, because very few people can measure lung function tests between 0 and 12 or 24 months of age. And that is the critical time of lung development and alveolar growth. It's critical. And so to be able to follow that longitudinally now with other measurements of spirometry or forced oscillometry, as well as other non-invasive techniques to quantify airway function or airway diameters, et cetera, I think is going to be critical to tease out some of the subtleties from this cohort that could be very important going forward.
Great, absolutely. And then my second question is, what do you think we need to see as clinicians, or I'm not a neonatologist, but the neonatologists need to see to actually change practice?
That's a great
In other
question.
words,
I think we should punt that to the panelists. Well, I mean, this is a very simple intervention that we use all of the time. We're just optimizing its duration. And I think in the past, you know, as neonatologists, we always want to make progress when we come on, and we used to see getting them off CPAP maybe as progress. But when you really think about lung development, being in utero, having a fluid-filled lung, it makes absolute sense that distension, and it may be even a critical post-menstrual age at the time of the distension, could impact subsequent lung development. So it's something that's is readily available, easy to apply, especially if you have a very good protocol in your NICU, because this is with bubble CPAP also.
Right.
And is there something with those oscillations that also could be contributory to the success? And can the CPAP be applied consistently throughout the babies in your NICU?
Yeah.
All right. Thanks, Dr. Davis and Dr. McAvoy. Dr. Nelin?
This is a great study, Cindy. I really am glad that you did this. I think this is really the first indication or first demonstration of a therapy that can be done in the NICU that actually changes longer-term pulmonary function. You know, we've gotten really good in neonatology at measuring neurodevelopmental outcomes. And we've actually, the NRN uses those as the required primary endpoint. But really, in a lot of kids born preterm, pulmonary outcomes are really, really important as well. So I'm not saying that neurodevelopmental outcomes aren't important, but there are more outcomes that are probably really important. And we've really focused laser focus as neonatologists on neurodevelopmental outcomes. I also want to talk a little bit about what you talked about, Cindy, and then what's been a little bit of an undercurrent of some of the comments, and that is preterm birth alters lung development. And so in the worst cases, we call that BPD. But we're not really good at knowing what BPD is, right? All we know is that those are preterm babies that have altered lung function that requires respiratory support with current definitions at 36 weeks PMA. But there's an increasing body of knowledge, particularly from some nice long-term cohorts in Scandinavia and the UK, where even kids born preterm without the diagnosis of BPD have altered pulmonary function into young adulthood. And so there's clearly something about being born preterm that alters pulmonary function. And so I think it's really important that this study didn't necessarily measure pulmonary function and this intervention in the kids that are at highest risk for BPD, because I think the outcome of improved lung function at 6 months is really, really important in this cohort that had a very low incidence of BPD. Because again, I think all preterm infants are at high risk for having decreased lung function later in life. And you showed that really well in that sort of what's now become a very standard picture of lung function versus age. And to move that, what I think, if I remember the colors right, was the blue lower lung function for preterm babies, to be able to move that up to the red function that normal term babies have is be really important. And this is a really nice demonstration of that. So we need to get better at understanding what preterm, long-term preterm outcomes, lung function outcomes are. You know, in the UK, they're starting to use words like prematurity associated lung disease, prematurity associated obstructive lung disease, and there's getting to be a larger awareness that preterm birth is a forerunner of later adult COPD. And in fact, in Europe, they're starting to wonder if BPD is actually another phenotype of COPD. And I wouldn't be, at least some of BPD, I think is that. So I think I really congratulate you on looking at this cohort of patients, because you took out some of those things. Like, you know, if you had showed this and then also showed that BPD didn't change, a lot of neonatologists would have gone, who cares? But I think it's really, really an important finding. I think the fact that we can do something in preterm babies who don't get BPD that improves their lung function at 6 months of age should change the way we take care of patients in the NICU. And I'm not sure how much evidence we need for something as simple and safe as nasal CPAP. And you showed in this study that there weren't any adverse outcomes for extending CPAP, and I think that that's really important. I think an important question going forward, aside from following this cohort as long as you possibly can, would be looking at how long should that CPAP be? Should it be 2 weeks? Should it be 4 weeks? Should it be 1 week? And I think what level of CPAP is it? Is it 5? Is it 3? Whatever it is. Clearly 5 works, and that's probably the right number. And then I think that there's been a big change in neonatology in terms of using high flow nasal cannula to try to not use CPAP. And I think that's probably a bad thing overall for long-term outcomes in these patients. And so being able to show that CPAP is really important, I think is going to be something that should change our practice. Now, whether it changes our practice around high flow nasal cannula, I think it should, but that's my own personal bias. And I think that's something that should be studied in the future as well, whether high flow nasal cannula has the same distending pressure effect or not. And my personal bias is that it probably doesn't, but I think it'd be really interesting to look at. So that's a big, long comment. I really like this study. And I think it's a very, very important study for neonatology and pediatric pulmonary going forward.
Well, great. Thanks for that answer on all of those comments. Just to respond to a couple of your comments in terms of high flow nasal cannula, we do have data from our primates center during the study I mentioned, where we actually measured the changes in the transpulmonary pressure with our primates on CPAP, which I mentioned. But then for the sham CPAP, we kept them off CPAP, but slowly we increased just the high flow. And guess what? There was no change in the transpulmonary pressure. So nothing in that model being distributed to distend the lungs. So I think there's a very important consideration when we're looking at the potential of CPAP and mechanical distension to improve lung growth and development, because from that data, my bias is that high flow nasal cannula does not provide the same descending pressure to the lung. And then also, in terms of, again, this population, I think this is an incredibly important population, not that BPD isn't important, but like in terms of absolute numbers, like this is much higher. And this is something we can easily do. And we also did do neurodevelopmental exams at 12 months of age. And there was no difference between those scores. Of course, this was 100 total patients. But we're digging into that a little bit more, just to look at the different fractions of the neurodevelopmental outcomes. Also, during these 2 weeks of treatment, we had a second pulse oximeter on the patients, the Masimo Radical, which gathered data every 2 seconds versus the standard, which is either 8 seconds or even up to 15 seconds. And it was very interesting. We presented our results at the PAS this year so these were all stable infants, all on room air. And we looked at a variety of intermittent hypoxemic episodes. And on room air, the CPAP patients had significantly less episodes of intermittent hypoxemia, which I think is also incredibly important as we're thinking about the benefit of keeping patients on CPAP longer.
Thanks. And then we have one more panelist to hear from, Dr. Welty, but Dr. Comborley, so we see that your hand is raised, so we'll move to you as soon as we hear from our final panelist. Dr. Welty?
Can you hear me?
Yes.
This is the disadvantage to going last, because I just want to say I agree with all the questions and all the comments made. And then I'm kidding. So first off, Cindy, congratulations. I too was a member of the DSMB, and so much of good outcomes is dependent on culture. And I think your work probably demonstrates the culture. As I go from place to place and look at stuff, there can be within one place terrible inconsistencies with the type of non-invasive support, the interface of non-invasive support, and the strategy for non-invasive support in the same institution. So I want to congratulate you on the culture that I think you probably have. Number two, I love the idea that you don't alternate between mask and prongs. I'm just going to say that as a bias. And I love Hudson prongs, and I love bubble CPAP, and I love the fact that you say in your paper and when you talk with us that CPAP, not NIPSI, not NIB-NAVA, has been shown to be the most efficacious. And I don't want to get into a fight about that, but I just really want to comment. I really want to congratulate you on what looks like developing consistency. I would also, the other thing I would say is that I'm very impressed. If I were going to choose a cohort that I would expect to see no difference, I would choose babies that were born at 1,400-ish grams at 29, 30 weeks. And because they were at 32 weeks when they met discontinuation criteria, I would have expected there to be no difference, because that is a patient population, and this may get at what Leif's talking about. That's a patient population with very little obvious lung injury to the clinical neonatologist. So the fact that you saw like a 25% difference in some of your measures is astounding. I want to congratulate you. And I agree with everybody else. The big hitters, and we'd love to hear what you plan to do. The big hitters are the little tiny guys that kind of age out or never meet the inclusion criteria because they're just a little bit too sick. Just a couple questions. Well, the other comment, before I get to my one question, the other comment is the tension between nasal CPAP and Q-based feeding. And sometimes, you probably took many of your babies to 33 to 35 weeks, and we find it's queuing then. And the question is how do you deal with that other than ignore the queuing? So that's the question. I had one last the other question is that in your discontinued nasal CPAP, it looked like over 20% of them had to be put back on nasal CPAP. And I wonder if you looked at the discontinued nasal CPAP in the 10-ish or so patients that had to go back on CPAP versus those that never did, to see if any of their measurements were a little bit different. I recognize you lose all your power. I would be okay looking for a trend.
Both great questions, Steve, and thanks for those comments. In terms of Q-based feeding, I think that's a great question. Where in our study we didn't have issues with patients showing readiness for feeds, but I can see that could be occurring as we go forward. And I think it's important to emphasize that the CPAP that we're giving to these stable infants is not necessarily because their FRC is diminishing when we take them off. It's to, we don't know what the optimal duration is of that mechanical distension to optimize the lung growth. So I think that, as these issues come up, if they're truly showing cues and they're still on CPAP, we might consider just trying to coordinate the time at the breast or the bottle during their CPAP cares to minimize their time off CPAP. But again, I'm not sure that when the patients are stable that we're completely worried about losing their FRC, as we would if patients who are on CPAP who are not meeting respiratory stability criteria yet. And we looked at the patients who failed and had to go back on CPAP, and they tended to be the smaller patients, but I need to look at their measurements a little bit closer.
I love the idea that, my last comment is, I love the idea that you're doing structure function studies, which is really what these are. And I won't insist on you biopsying the lung.
Well, what we hope if we get further funding is we would love to continue to follow them serially with spirometry and forced oscillometry, and then more detailed phenotyping, and then get, either likely a low dose CT scan or MRI to look at their structure and related to the function, when they're a little bit older, 8 or 9 years of age.
Thank you.
Thank you.
I'll open the floor to questions. Dr. Komborlis, you had your hand up for a while. Thank you.
Okay. Thank you very much, Cindy. This was an amazing presentation, and I'm extremely envious. I wish I could be part of that study. I would like to introduce one more element in support, actually, of what you have done. The CPAP does not affect only the lungs and the development of the lungs. It's affecting also the chest wall in a positive way. And we know that premature infants have incredibly, soft structures. They are very prone, if they are in distress, to develop thoracic abnormalities. And in this case, you may have actually a double benefit or a triple benefit because you distend the lungs, you prevent malformations of the chest wall, and if you believe the current trend about respiratory training, respiratory muscle training, you do the same things, because you allow them. So it may be actually a multifactorial benefit from doing what you did. Thank you very much for the
Yeah,
study.
great. Thank you. Thank you for those comments. Chest wall stability, incredibly important for maintenance of FRC, as you mentioned, and also muscle training is another good point. Thank you.
I'm just going to read some of the questions from the audience from earlier. I think from Dr. Barry Weinberger. Does sham CPAP obstruct the nares? And I think this refers to maybe the primate study.
No, because the interface is the same. Hopefully that answers the question.
Yes. I think some of the other questions have been like, was baseline FRC measured on CPAP? I guess that's more of a technical question.
No, we unfortunately had to take them off. So we would take them off CPAP and then immediately measure the FRC.
And then from Stacy Peterson Carmichael, what do you think are physiologic reasons for higher forced expiratory flows in the DCPAP group versus ECPAP group? Airways size relative to lung growth / lung volume.
That's a great question. And there are several animal studies that have also shown improved forced expiratory flows after CPAP. So I think your question is right on, asking if it's the airway size relative to lung growth. And that's why we would love to be able to do a structural assessment by CT or MRI of the airway structure. Thanks, Stacy.
Dr. Manny Duran said, very important study, but I think you answered this question about intermittent hypoxemia between the two groups. And Dr. Cohen just commented that it will be so interesting to see if this cohort has lower incidence of bronchiolitis, preschool wheeze, and asthma that we see in the moderate preterm population. I hope you get to follow them longitudinally.
Me too.
I think that's the extent of our audience questions, unless somebody else wants to ask in person.
If anybody wants to email me with questions after, I'm happy to answer. So.
All right. I think we are a little over our time, but this was a great discussion. And thank you so much to Dr. McAvoy and our panelists and to our audiences for being engaged. I hope everyone has a good day.
Thank you. That was wonderful.
Great. Thank you. Thanks, everyone.
Thank you all.